Welcome to Ask Dr. Mingle, the Q&A series from Mingle Health answering your questions about quality programs and the transition to value-based care. I'm Kyle Breckel. I'm a digital marketing specialist here at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Hi, Dr. Mingle.
Good morning, Kyle, and good morning to all of you tuning in. It's great to see you again. I'm Dr. Dan Mingle, and I'm here to answer your questions to the best of my ability.
Well, we have a great set of 5 questions for you today, Dr. Mingle, so if you're ready, let's jump right into them.
Bring it on, Kyle.
Okay, our first question for you today is from Gillian, and Gillian asks, how does the scoring change for the APP Plus, that is the APM Performance Pathway Plus, measure set when more measures are added each year?
Great question, Gillian. As you know, in the final rule for 2025, Medicare added the APP Plus measure set. Starting in 2025, Medicare Shared Savings Program, that is MSSP ACOs, must submit the APP Plus measure set and meet or exceed the quality standard in order to collect all of their shared savings or avoid maximum shared losses. Now, other APM models can elect to use the original APP measure set or the new APP Plus measure set if they wish. Neither set is available to traditional MIPS or to MVP, that's MIPS value pathway participants. The measure set is scheduled to gradually increase to include all of the adult Universal Foundation measures. The Universal Foundation is a set of measures that Medicare has been organizing in a group to manage those in order to synchronize quality reporting across their many programs. Now, scoring of the APP Plus depends on your circumstances. ACOs in the first year of the participation cycle remain in a pay for reporting mode. Making a successful submission of all measures with each meeting data completeness and minimum patient counts is all it takes to qualify to collect shared savings. If you're submitting the APP Plus measure set using Medicare CQMs, you must hit the usual quality standard. Each measure can earn between 0 and 10 quality achievement points based on the decile ranking of the measure performance against peers. The total score is calculated by adding the total possible points as a denominator and the total earned points as the numerator. You collect all of your shared savings if your aggregate score meets or exceeds the quality standard, which is now the 40th percentile. Doesn't matter how many measures apply. You will get one aggregate score represented by your total earned quality achievement points divided by your total possible points. If you're submitting MIPS CQMs or eCQMs, Medicare is offering an alternative quality standard to incentivize participation in all patient, all payer measurement of quality. The alternative standard looks at individual measure scores rather than the aggregate or composite. For the alternate standard, the more measures there are, the more chances you have of achieving the alternate standard. The alternate standard is one outcome measure has to have a score hitting at least the 10th percentile. Any second measure must be at the 40th percentile. You should also be aware that there is a new complex organization bonus for which one achievement point is added to each individual measure score that is submitted by an ACO as an eCQM. The bonus is not permitted to bring an earned score for any measure above a perfect 10 points. They are not explicit as to how this bonus interacts with the alternative quality standard, but I expect the standard is applied after the bonus is calculated in. Thanks for the great question, Gillian.
Yeah, thank you, Gillian. And Gillian has another question for you today, Dr. Mingle. She asks, is the calculation for the 2 claims-based measures for MSSP the exact same as in ACO REACH?
Great question, Gillian. And the answer is no. You're referring, I think, to the administrative claims measures. First, hospital-wide 30-day all-cause unplanned readmission rate, which is MIPS measure number 479. And then number 2, the clinician and clinician group risk standardized hospital admission rates for patients with multiple chronic conditions, which is MIPS measure 484. Now, we see these 2 measures in at least 3 places. These specific measures are included in every MVP. And starting with 2025, Medicare is going to calculate these for every MVP submission and give each participant the benefit of the best of the two scores. These two are also included in both the APP and the APP plus measure sets. Measures like them are amongst the measures on which REACH ACOs are evaluated. When used in MIPS MVPs, the APP or the APP plus measure sets, these are precisely the same measures. But regarding REACH, Medicare deliberately describes the REACH specifications of these measures as based on but not identical to the MIPS specified measures. Even the format of the specifications documents are different. So if and when Medicare changes any of the specs on the MIPS measures, they will not be necessarily coordinating this with the REACH measure specifications. The measures clearly differ in eligibility criteria and may differ in adjustment methodologies and other details. Now, a limitation of my analysis is that the formal or the full spec for the REACH measures is not readily available, but the summation available does show that they do not match. Thanks, Gillian. Great question.
Next up, we have two variations on a similar question, one from Zach and from Gillian. So Zach asks, in the 2023 results, only 45% of ACOs got a value for measure 484, all-cause unplanned admissions for multiple chronic conditions. It was fully populated in 2022. Do you have any idea what happened in 2023? And Gillian asks, CMS is keeping the clinician and clinician group risk standardized hospital admission rates for patients with multiple chronic conditions for performance year 2024, but removing it for performance year 2025, and then bringing it back for performance year 2026. Do I have that right?
Great question, Zach and Gillian. I've grouped these questions together because I believe them to be related to the same issue. There's a problem with Measure 484. The specifications exclude patients that are attributed to a provider who achieves qualified participant status for the performance year. Interesting, in a measure that's applied to advanced APMs whose participants are possibly all qualified participants. Now that measure is being used in that APM performance pathway, advanced APMs are subject to exclusion of many or possibly all of their patients from the measure calculations. Now, I'm not entirely certain that this is what Zach is observing, but it's certainly possible. You're going to see a lot of noise in the process, particularly as practices move from a one-sided risk model or MIPS APM model to an advanced APM model. When they can't, the participants can't be QPs in the MIPS APM model, and they are likely to be in the advanced APM model, and suddenly lose all of their patient eligibility to be included in the measure. I'm more confident, Gillian, that this is the reason why the measure is gone for 2025, then back again in 2026. Specifically, it's continually present in the APP measure set. Always there, never gone. CMS chose not to bring it forward into the APP plus measure set while they decide if its specifications should be changed. They're explicit about this in the 2025 final rule. Now, I think they should change the specifications. The reason they give for having the exclusion to begin with is that QPs do not participate in MIPS. But now that all ACOs are subject to the measure, QP patients should be included in the measurement. It's just as important for QPs to prevent the need for hospitalization as it is for all other clinicians. And I'll be making that my comment as the rulemaking rolls around. Excluding patients attributed to QPs renders the measure less valid for alternative payment models for those advanced ACOs. Thanks, Zach and Gillian. Great question.
Yeah, thank you both for the great questions. So our next question for you today, Dr. Mingle, is from Jason, and this one has a little bit of context, so bear with me as I read it. We spoke with an ACO that serves the post-acute space. Patients seen in skilled care, place of service code 31, are limited to a short stay and are excluded from attribution. Though the intent is to get them home after a short rehabilitation, Many are discharged to long-term care, place of service code 32, which has no limitation on duration and is eligible for attribution. The ACO continues to provide care to these patients for the duration of their stay in long-term care. This ACO finds that many of these patients discharged from long-term care to home after a few months do not establish with a community primary care provider and remain attributed to the long-term care providers who don't have a venue in which to continue serving them post-discharge. Are there any specific strategies or best practices you'd recommend to address this attribution challenge?
Oh, great question, Jason. I can see how those patients become a risk to an ACO's cost performance. Controlling that risk is a challenge. Now, I see two domains to start thinking about how to address that risk and contain it, control it. The first is discharge planning, upping your game in that area. And the second is to improve that transfer in responsibility, solidify it, systematize it. On that transition from long-term care to home, one set of risks is to the daily care plan. On the transition to home, there's dramatically less supervision, monitoring, and supportive activities of daily living. Compliance levels do change commonly and sometimes dramatically in terms of exercise, diet, and medication. Costly events become more likely, mostly related to decompensation of fragile chronic conditions. But falls and other injuries also contribute to the risk of high cost events. And with those events, of course, decompensation of fragile illnesses, major injuries, rehospitalization is a very costly event that affects this population. Now, control this by upping your game in discharge planning. Mobilize the family and mobilize community care teams. Take it seriously in every discharge. Never assume it's going to be smooth or easy. The other risk is to get lost to medical follow-up or simply confused or delayed in the transition. Prior studies have shown that people who have a primary care provider, know who it is, and have access to them enjoy better care and lower cost of care. So getting lost in that transition can be a risk to the cost and quality of care, essentially. Control these risks with better planning for the transitions. I suggest meeting with regional primary care providers to secure agreements that they accept your patients on transfer to home and that you together outline the expectations, who does what when the transfer happens. Now, you should consider as part of the handoff an annual wellness exam through the new primary care provider. Suggest it, insist on it. It would nicely facilitate both the transition of care and the transfer of attribution. An annual wellness exam is a great review of the patient's comprehensive needs, a great introduction to a new provider, and its billed performance takes precedence over most other triggers of attribution. So with that one move, you make the transfer better, more solid, and affect that transfer of attribution that you'd like to see. Now, consider facilitating the kickoff of that annual wellness exam within your own discharge process. Distribute or even administer a standard risk assessment tool, leaving the final analysis and billing for the service to the new PCP. As an additional solidification of the transfer of attribution, consider helping the patient name the provider who is accepting the patient in transfer as their new primary care provider through Medicare.gov. In most cases, this prospective attribution takes precedence over all other methods. Now, some reasonable combination of these approaches that I outlined is simply good health care and effectively transfers the care and responsibility and can facilitate that transfer of attribution to the new provider so you don't suffer from any other cost events that come down the pike for those transferred patients. Thanks. Thanks for that question, Jason.
Yeah, thank you, Jason. And our final question for you today, Dr. Mingle, came from Adnan in a YouTube comment. So thank you for the YouTube comment, Adnan. And Adnan asks, how do we, as billing professionals, help protect providers from MIPS penalties?
Great question, Adnan. I think that billing professionals are in a unique position to provide protection for their clients through guidance, information, and service in support of the quality payment program, the merit-based incentive payment system, that's MIPS, and other value-based payment programs. There are three things I'd suggest revenue cycle organizations endeavor to build into that client relationship. First, you can routinely alert client practices to the existence, the risks, and the benefits of various value-based programs that may affect them. Second, you can keep client practices apprised of important due dates, when you have to submit an application, when you have to declare certain choices. Provide guidance and or technical support for your client practices to access and submit their data to the vendors they've engaged to help them with their value analytics. Now, the unique position that revenue cycle organizations hold with those clients relates to three elements. Revenue cycle organizations often have a closer relationship and deeper knowledge of the insurers, that their requirements in their value-based programs, than do the practices they serve. Even if unvoiced, practices are looking to their revenue cycle partners for help, both to identify and reap the revenue benefits from such programs and to avoid revenue losses. Second, the foundation for measurement of value is built on visits and claims. Together, visits and claims define the patient-doctor relationship. It defines the range and volume of services provided within that relationship and the range of diagnoses, injuries, and illness that drive individual patient needs. This is the gold standard data set that determines eligibility, both of practices for specific programs and of patients for specific measures. Finally, there is typically a foundation of technology in the relation of revenue cycle organizations with their clients. Revenue cycle companies routinely interact with the practice management and billing data of their client practices. They sometimes have a role in the clinical EHR data of the practices they serve. They can be of invaluable support to their clients to help them access and deliver data to the vendors that help them analyze and submit quality measures to CMS and other insurers. Mingle Health has partnered with many revenue cycle companies. Too often, revenue cycle companies reach out to us after one or more of their clients have already experienced a loss. Now, earned or not, revenue cycle companies are first in the path of blame that their practicing clients assign for those losses. In that relationship between us and the revenue cycle company, it's a nice way for us to get contact with a large number of small practices. You facilitate a relationship that would otherwise be difficult for us to scale. Now, in some cases, that relationship that we foster with a revenue cycle company is as a preferred vendor. So the revenue cycle company recommends our services to their client practices, and the client practices engage us directly on that recommendation. To others, that the revenue cycle company is a value-added reseller. Those revenue cycle companies typically maintain the vendor-client relationship, buying Mingle services at wholesale prices that they resell to their clients, and then add value by delivering the standardized data sets that we use to generate those annual quality submissions. In both cases, Mingle can provide the revenue cycle company with updates on the changing environment of program risks, opportunities, and deadlines, and help you keep your clients informed of those important programs and deadlines. Great question, Adnan. Thanks. I look forward to dealing with you and your clients.
Thank you for the great question, and thank you to Gillian and Zach and Jason as well for their questions. And thank you, Dr. Mingle, for sharing your insight with us today.
Thank you, Kyle. And thanks to all of you for your great questions. I want to be helpful. I want this to be useful to you. Don't hesitate to correct or supplement my answers. Share your experience. Ask your questions. We can be smarter together.